one of the first challenges is to think of TB at all and to diagnose it. And therefore we are very excited to have, I think it is James first, James Seddon with us. He will give a presentation on a common sense approach to the diagnosis of TB in children. James is honorary associate professor from Stellenbosch University and also senior lecturer of Imperial College London. So could we have James' presentation?
Great, thanks very much, Alexandra. It's a huge pleasure to be talking at this event. Next slide. And what I'll be talking about, as described by Alexandra, is I'll be trying to give a sensible approach to how we should be thinking about the diagnosis of TB in children. Next. So as alluded to already, just over 1 million children develop tuberculosis each year, and a quarter of those die. This modelling study that I was involved with a few years ago shows where children are dying of TB. You can see from the chart on the left and the map on the right. These are areas where there are lots of children, there's lots of TB, and generally there's a lot of poverty. And the WHO guidance, or the WHO report last year updated their numbers to reflect these estimated burdens. Next slide. However, what's striking for me in these modelling exercises is looking at which children are dying. From this mosaic plot, you can see that to the left, the sort of 4 boxes to the left, they're HIV negative children, and the 4 boxes to the right are HIV positive children. The top sort of half of the figure is children under 5 years, and the bottom half is 5 to 15. But what's really striking is the large brown square, the blue square, the green square, and the pink square. These are all untreated TB. About 96% of children who are dying, who have TB, are dying because they haven't been diagnosed. And we have a massive problem in the diagnosis of child TB, leading to huge amounts of child death. Next. And really, there are a couple of messages that I'd like you to take away from this talk. The first is that the first step in diagnosing TB in a child is thinking of TB in a child. Once you started thinking about it, the diagnosis is actually not too challenging. And in most children, the diagnosed TB can really be made pretty confidently just on careful clinical assessment. Even if confirming the diagnosis can be challenging, but making the diagnosis is not so hard. Next. This is the basic epidemiology of child TB. You can see that the blue line in the figure represents the incidence. So you have a lot of child TB in the youngest children under 5 years. And then there's a nadir where they hit this golden age, primary school age from about 5 to 12. And then the incidence rises into adolescence through puberty. And also what you see is the type of TB changes with age. The youngest children, as you can see with these blue bars, have either limited disease, intrathoracic lymph node disease, you can see by the chest x-ray in the middle with the blue outline, or they have very severe disseminated disease represented by the red bars, which could be miliary TB, such as the x-ray at the top with the red outline, or TB meningitis. But as children get older and enter adolescence, they develop more adult type disease, as you can see in the green bars and the bottom x-ray with the green outline. These have cavities and extensive parenchymal breakdown. And the reason why this is relevant is because when you're thinking about diagnosing TB disease, these are the kinds of disease patterns you'll see. Next slide. So what about HIV? Well, this study, which was published nearly 30 years ago, and actually the situation for untreated HIV has not changed very much. HIV substantially increases the risk of TB in children. It also changes the pattern and the presentation of TB, and it makes it harder to diagnose. Often the radiology is less useful, and diagnostic tests are often positive less frequently, and outcomes generally are worse. HIV adds substantial complexity to the diagnosis. Next. And this looks quite complicated, but what I'm trying to show with this figure is that children can arrive in front of you in 3 main mechanisms if you go to the top 3 boxes. So either the child is identified through contact tracing, or the child is referred to you for some abnormal test result, or the child presents with symptoms or is brought to the clinic or the healthcare or the hospital with symptoms. But in all of these situations, the first thing you need to do is evaluate the child for TB disease. And that's really what the focus of this talk is going to be about. And if they have disease, you then need to start treating. But I think what's important, and the reason I wanted to show this slide, is if they don't have disease, that's not the end of the story. Because if they were referred to you through contact tracing and you rule out disease, you then need to think about whether they need preventive therapy or infection treatment. And if they're referred to you because of abnormal test results, well, you need to figure out what's causing that abnormal test result. And also, if it's because they were referred because they had a positive skin test or IGRA test, then you need to evaluate them and think about infection treatment. And if they do come to you with symptoms, with cough and fever and weight loss and other things like that, and you decide it's not TB, that's not the end of the story. You then need to figure out what is causing those symptoms and treat that appropriately. Next slide. And the first thing we need to do when trying to diagnose a child with TB is first of all decide who might have TB, because it's a very tough child to assume every single child in the world might have TB. So the first thing is we use a very sensitive approach to say, well, let's reduce the size of the bucket to a manageable group of children, and then we can investigate them more carefully. So the first thing to do is look for children who have cough, and these are fairly well established definitions of presumptive TB cases. Cough, fever, weight loss, TB exposure, or a suggestive x-ray. And as you can see from this figure, if you adopt a fairly sensitive approach, such as the line in A, you'll include the vast majority of children with TB, which is the red curve, but you'll also include quite a few children who don't have TB. And then the second part of trying to diagnose TB or make decisions about treatment is differentiating that right-hand group of the green arc from all of the red arc. Next. And what does WHO say? Well, it says all the kind of sensible things. You need to take a careful history, a clinical examination. If you can do a skin test, do it. Try and get bacterial confirmation whether possible. Do other specific tests and do HIV testing. And this is all very well and good, but it doesn't really tell you which of these are important, how to evaluate them, or which are more important than others. And I think that's becoming increasingly apparent that we need more data on this. Next. And I think that the diagnosis of TB has traditionally been seen as putting pieces of a jigsaw together. And I think this is absolutely right. But in the past, it was done, I think, with a form of alchemy to it. There was a sort of the wise doctor with years of experience assimilates these pieces of the jigsaw and kind of waves his hands and miraculously decides whether it's TB or not. And I think we're in an age now where we need to be bringing more data into this. Next. So traditionally, we would start with history and move through examination and then look at radiology and maybe immune tests and microbiological tests, and eventually look for resistance. Next slide. The problem with this, and the animation has gone in this, but what I was hoping to show with this slide is that on the left-hand side, we have a child who has very few bacilli in their body, and they might have a skin test. And then as the time goes on, the number of bugs in their body increases and the child may develop some symptoms. And time goes on a bit further, there are more bugs and the child might present to the health system and they might get sent home. So they then re-present to the health system a bit later when there are even more bugs, disease is more severe, and ultimately they might be sent home again. And it's only when they finally come to the clinic for the third time when they would be culture confirmed. If samples were taken at the first couple of times they came to the clinic, they'd probably be negative. And yes, you can get a confirmed diagnosis if you wait till the child becomes sick enough, but that means you're left with the x-ray on the right rather than the x-ray on the left. And what we need to do is we need to be diagnosing children earlier in this progression when probably they aren't confirmed, because actually that means we'll be detecting them at an earlier stage when it's easier to cure and they'll be left with less residual lung damage. Next. And I think this is a very valuable study that Ben Murray did about nearly 20 years ago, where he described the characteristics of cough. And cough is probably one of the most important parts of the diagnosis of child TB. And he described 3 different types of cough. The acute cough with a delayed recovery, that's the one in the left-hand figure that goes up and then slowly goes down. And if you look at the right-hand panel, that acute cough is normally a virus. Then you've got the up and down type cough, the recurrent cough, which goes up and comes down and it goes away totally and then comes up and then goes down. And those kinds of coughs tend to be either viral infections, repeated viral infections, or reactive airways disease such as asthma. And then the concerning type of cough is the persistent non-remitting cough, where you have the line, the dark line on the left-hand pattern, just going up chronically for 1, 2, 3, 4 weeks. And that kind of cough, there are fewer causes of this, and TB in a high TB burden setting should be high on your list of priorities. So it's really important when you're taking your history to not just say how long have you had cough, is to really go into detail about what type of cough it is. And I often actually draw this figure in front of the patient and ask them to sort of point to which one best represents the type of cough they've got. Next. And Ben Murray also did a really nice study, which is the first study I'm aware of that really tried to quantify the contribution of different symptoms to the diagnosis. And you don't need to look at these numbers, but I want you to appreciate that you can actually take large cohorts of children who have presumptive TB, of which some have TB and many don't. And you can look at different characteristics and work out which are the best at discriminating between the two. What is the sensitivity of 4 weeks of cough versus 3 weeks? What is the specificity of chest pain? And it's really important to start bringing some data to these clinical signs and symptoms. Next. And this was done in a really nice study by Olivier Marseille and his group in the Panther study, which did exactly this. They took a large cohort of HIV positive children who had been evaluated for TB. About half and half had TB and didn't have TB. And they collected lots of data and they did some complex mathematical work to really give different weight to different characteristics. So if one characteristic was really good at discriminating TB from not TB, you give it more points. And if something wasn't very good, you give it fewer points. And then you can actually build a data-driven algorithm for how you start diagnosing TB in children. Next. And we in Cape Town have done something similar in this study that we just published recently, which did the same for HIV negative children. And again, feeding data from large cohorts of children with and without TB, but who have been evaluated for TB, can start giving us, rather than this alchemy that previously has been used, some data to try and make decisions about when we should start treating children, TB in children. And I think of note, the WHO are revising their guidelines this year, and this kind of approach will be feeding into that revised guidance. Next. What about radiology? And again, the animation has not come through on this slide, but what I wanted to show is that there were the two circles in the overlapping Venn diagram. On the left, there's a child who does not have TB, the left-hand circle, and on the right-hand circle is a child with TB. And then in the non-overlapping bits, there's characteristic features of something other than TB or characteristic features of TB. And yes, there are certain features on an X-ray which generally many of us clinicians intuitively feel, oh, that's pretty characteristic. So if you see hilar lymphadenopathy, you see parenchymal breakdown in cavities or miliary pattern, that nudges you towards TB. But there are many patterns, and the X-ray in the middle really could be TB, or it could be some other kind of pneumonia or other type of infection. And again, we need data to arrive this rather than expertise. Next slide. And so this was also done by the Panther group, which again is trying to give some data to the different characteristics you see. And some features are very specific. If you see them, they very likely have TB. Even if they're not very sensitive, that can still be a very useful sign, because if you see them, that helps you. There are others that are quite sensitive, but not very specific. And sometimes that doesn't help you quite so much. Next slide. And we're doing the same thing again in Cape Town now and finding very similar things. And it's again putting some numbers to the gut feel that we've had for many years. Next. And this is many of you may have seen this atlas on chest radiology that's written by Rob Gee, who's the gentleman on the left of this photo receiving an award from the union, which has been used as a Bible for many people to interpret chest x-rays. That is going to be revised this year as well. And again, we're trying to build in a lot of data in this next atlas to tell us exactly how useful the different features are in a chest x-ray. And I'm just going to pause for a second before moving on to say, for the vast majority of children, this is enough. Clinical signs and symptoms in radiology should be enough to make a decision about child TB. So the rest of this talk is really if you have additional resources. Next. And when you look at a child with TB symptoms, the additional tests you might be able to do is you might be able to identify the host response to the organism, or you might try and find the organism yourself. Next. So the host response, obviously there is the TST and the IGRA, not available in most places where there are lots of children with TB. TST is very challenging. It requires 2 journeys to the clinic, and often it has to be kept in a fridge. And IGRAs can be expensive and require incubation and aren't really recommended. And there is not perfect tests. These don't tell the difference between TB, infection and disease. And if they're positive, they're kind of helpful. But if they're negative, you can't rule out disease. So these are kind of a useful additional piece, but they're certainly not the answer. Next. And there's so much biomarker work being done currently, and I'm not going to go through all of these by any means, but there are metabolomics, which is the top left, there's proteomics bottom left, there's the transcriptomics in the middle, there's exhaled volatile chemicals, and then there are things like LAM, which is a compound on the outside of the organism. Next. But I am going to talk briefly about LAM, and I think this was an important study which was published earlier this year, which looked at the old Aller LAM, which is the one on the left, and the new Fuji LAM. And these are children being evaluated for TB, and although these are not perfect sensitivity and specificities, actually they're not bad. And having a sensitivity of 65% with a specificity of 84% is not bad against a microbiological reference standard. And even against a composite reference standard, the sensitivity is lower, but this could be an important part of the puzzle, not the whole bit of the puzzle, but an additional useful piece of the puzzle. Next. And I think the other bit that I wanted to mention is the transcriptomic studies, the gene expression studies. And this was a landmark paper in the left by a group at Imperial, who found a signature based on genes that were up or down regulated that could discriminate children with TB from children that couldn't. And although this is clearly just a research idea in a high income setting, actually people are developing point of care tests, and Cepheid have developed a cartridge, a treatment response cartridge that could probably go into a gene expert machine that will measure a small number of transcripts. We haven't got it for children yet because children probably have a different signature to adults, but there is space for this, and this could be something we could use in the future. Next. What about finding the bug? Next slide. So we first of all need to get a sample. There are thousands of papers that ask whether it's better to get a gastric aspirate or induced sputum or this or that or whatever. And the bottom line is it doesn't really matter. If you get a good quality sample, ideally 2 good quality samples that originally had stuff from the lungs, whether it's coughed up sputum or sputum that's been swallowed into the stomach or sputum that's coughed up from the lungs into the stomach and out through the intestines, just make sure you get good quality samples. Next. But I did want to talk about stool because it is the sort of exciting area that everyone is interested in at the moment. And although stool is not perfect, it doesn't have 100% sensitivity or specificity against a reference standard of a cultured sample from the lungs. It's not bad and it's easy to get. And so I think that if you do have the opportunity to collect stool and you have the opportunity to process it with Gene Expert, and if it's positive, this is a useful additional test. Next. But with all these microbiological tests, there is a relationship between age and severity. So as children get older and as children have more severe disease, you have a higher chance of confirmation. And so the children who are young, especially with the intrathoracic lymph node, more non-severe disease, your chance of confirmation is much lower. Next. And what about identifying the bug? Next. Well, we can do microscopy. Which still is of some use, but will miss the vast majority of children. And you can do fluorescent microscopy as well. Next. But we really want to be doing culture. On the left is solid culture, and on the right is liquid culture in midget. And this really is still the gold standard for identifying organisms in children. Next. And we can also look for bits of the organism that we can multiply up, bits of the genetic material of the organism. Next. And the real game changer that came through 10 years ago was the Gene Expert machine, and the new iteration, the Expert Ultra, which you take samples, respiratory samples ideally, but can be used on other samples as well. You put them in the cartridge, and 2 hours later it tells you whether you have TB, yes or no, or whether you have resistance to rifampicin, yes or no. And this is an important development, and I think that if you have this, it's important to try and use it as much as possible, because a positive result can help. Next. And the Ultra is, when you look at these in children, okay, again, it's not quite as good as a cultured reference standard, but to have a result within 2 hours, the Ultra coming through is almost as good as culture, and you get a rapid result with drug resistance. There is also a cartridge coming out from Cepheid soon, which will not only look at rifampicin resistance, but will also look at isoniazid and the fluoroquinolones. And I think that will be a real important next step when that comes through. The Hain test, these are line probe assays. So once you either have a direct clinical sample, or probably more likely for children when you have a cultured positive result, you can subject it to a line probe assay. And this is also a genetic test which looks for resistance mutations. The one on the left is the first line that looks at isoniazid and RIF mutations, and the right-hand one is the second line Hain test as well. And these are useful because they give a result quite quickly and can give you more detail than the expert currently does. Next. But I think the important thing to say is that if you have 10 children who have TB, 1 out of 10 will be smear positive, maybe a couple out of 10 will be expert positive, and the gold standard, the culture, only really 3 or 4 of them will be culture positive. So the majority of children you need to be thinking about with TB, you will have negative microbiology, and they need to be started on treatment based on the clinical signs, symptoms, and radiology. Next. What about the trial of antibiotics? This is commonly done, and this was a systematic review, admittedly in adults. So it's, there's very little data on this point in children. And the authors on this paper suggested that these sensitivities and specificities of 67% and 73% in the forest plots here were very poor. I actually think this is quite helpful, and it, tests that can add this value can really add an extra contribution. I think in children, whether or not it's the antibiotics or it's just time, I personally think that just waiting a week or 2 weeks, if you're not sure if it is a viral infection or some other kind of infection, often the symptoms have changed within a week or 2, and the picture is slightly different when you reassess them in a week or 2's time. And if you've given a course of antibiotics as well, that kind of takes the bacterial infection out of the equation, and you can reassess. Next. So this is my kind of idiot's guide to diagnosing TB. There are also quite good algorithms in the Union Desk Guide, which really follows the WHO guidance. And as I'd say, later this year, the WHO will use a data-driven approach to develop an algorithm that uses individual signs and symptoms to try and allocate decision-making choices. But for me, the first step is to decide if the child might have TB. So you first of all decide if there are presumptive TB cases. And then you take a really careful clinical history and examination. And again, try and use data, try and use sensitivities and specificities to make a decision about which features are important. And many children at that point, you can be really reassured that they probably don't have TB. And other children, you can really be very confident they do have TB. And at that point, just start treatment. If you are in a position where you can get microbiological samples, then you should try and take them, because it can confirm the diagnosis. It might tell you about resistance. If you're still a bit iffy, you're not sure, you don't want to be reassured, but also you're not confident enough to start treatment, then doing an X-ray can be helpful. And again, use the data to tell you which features on X-ray should reassure you and which are really quite specific for TB. And then if your X-ray is still not that helpful, then at that point you can try and confirm the diagnosis, which if it's positive can help. But if it's not available or it's negative, then I think a reasonable approach is to try and see the child again in a couple of weeks. And if they have symptoms of a bacterial infection, you can give some antibiotics as well. Next slide. So in conclusion, globally, many children are not diagnosed and treated. And actually, most children who die of TB are dying because they are not diagnosed. But most children can be diagnosed with clinical symptoms and signs, and there is a role for X-ray and for microbiology, but really most can be diagnosed without this. And I think that in 5 years' time, we will be in a very different place in childhood diagnostics with much better biomarkers, much better microbiology, and we'll have a more data-driven approach to the signs and symptoms and radiology. So thank you very much. And I think later on in the session, I'll be delighted to take some questions.